This is my presentation for the ground round presentation. This is a patient, is the initial RGA, the clinical site is West Miami Rehabilitation Hospital. The chief complaint is headache, a history of present illness. 87-year-old Hispanic female is brought in because of she was found at home lying on the floor with strikes of scattered blood over her head about 5 days ago, and ever since has been speaking incoherently, unintelligibly, and seems to have headache. Patient was initially conducted to a trauma center where CT of head and MRI of brain has been non-conclusive, and then she was transferred to this hospital for rehabilitation and further evaluation and continuum of care. Allergies, non-known drug allergy. Current perception of health, unable to assess. Past medical history, hypertension, hypercholesterolemia. Past surgical history, open heart surgery for aortic valve replacement 1 year ago. Hospitalizations, the same 3 years ago for the valve replacement. Current meds, simvastatin, atenolol. Family history, mother passed away with dementia, father positive for heart attack, however after 65 years old. Social history, married. Family, she lives with the family. Smoke, non-smoker. Alcoholic beverage, she denied consumption. The family denies consumption, as well as recreational drug use. Revision of system. Most part of the system, the information is impossible to assess because the patient doesn't speak in an intelligible form. But according to the relative, they have no notice of having fever or weight loss for head, ear, eyes, neck, and throat. No notice having ear pain or discharge, nor epistaxis noticed. Common cold or sore throat. Neck was not complaining of pain before. Family denies patient having cough of dyspnea. Cardiovascular patient use to sleep with only one pillow. Only the past surgical history above referred. Breast, no problem reported. Gastrointestinal, no nausea, vomiting, or diarrhea reported. For the genital, no lesion or discharge reported by family. Genitourinary, no dysuria or back pain reported. Neurological, the same as a history of present illness. Activity and exercise limited. The patient is not too much active at home. Musculoskeletal, no muscular disease known by family members. Psychosocial, patient already have treatment for agitation by outpatient psychiatrist with quetiapine, Seroquel. No lesion reported on dermatology. Nutrition, patient was eating homemade meals low in sodium and fat, but with poor appetite lately. Sleep rest, patient has sleep patterns inversion at home. Physical examination, the objectives. Blood pressure 120 over 80. Temperature 98 Fahrenheit degrees. Respiratory rate 12. Heart rate 72. Height 5'3". Weight 136 pounds. Change 65 kilograms. BMI 23. Last menstrual period unknown. General. March, the patient is now bedbound. Fascias with no dysmorphic features, no periorbital hematoma or discoloration. Ears, eyes, nose and throat, no ear bleeding or discharge, no nasal bridge lesions, no signs of nasal bleeding. Throat, no erythema or exudate. Neck, no nuchal rigidity. Pulmonary, normal thoracic excursion, normal vesicular sounds, no rels. Cardiovascular, regular rate and rhythm, no murmurs, rubs, or gallops. Breast, no skin change, no masses on palpation. Abdomen, soft, non-tender, not distended, no hepatosplenomegaly, bowel sounds positive in normal intensity for quadrants, rectal normotonic sphincter, no masses, female genitalia, normal external appearance, no bleeding, discharge or lesions, musculoskeletal, no bulk atrophy, no fasciculations, neuro, alert, speech, language, unintelligible, cranial nerve 2 to 12 grossly intact, muscular strength symmetrical, upper, no drift in upper or lower limbs, dermatology, no visible wounds, no hematoma or ecchymosis, psychologic, alert, language, speech unintelligible, no abnormal movements. The rest is unable to be assessed. Now, our assessment. Traumatic or non-traumatic brain injury. Differential diagnosis. Multi-infarct dementia, Alzheimer's disease, normal pressure hydrocephalus, Lewy bodies dementia, encephalitis, subarachnoid hemorrhage, intraparenchymal hemorrhage, delirium. Significant data contributing to the diagnosis. CT brain without contrast, absence of intracranial bleeding observed. MRI brain, no bleeding or tumor found within brain parenchyma. 3-view skull X-ray, no fractures observed. Plan. The patient is currently admitted in a rehabilitation facility. So consult physical therapy for continued physical therapy. Consult speech therapy with a focus on swallowing if there is any swallowing problem. Consult neurosurgeon and neurologist, basically to handle. We are following recommendation from them in order to manage the brain injury. Consult infectious disease just to rule out any subtle infection trait, and consult the social worker for helping the family to cope with all the needs that arise after a brain injury. We have been following the current evidence-based guideline for Brain Trauma Foundation Guidelines 2022, the Clinical Practice Guideline, Head Injuries, the Head Trauma Stat Pillars, and the initial management of closed head injuries for American Association Health Management of Acute, Moderate, and Severe Brain Injury. Currently, the diagnosis of the brain injury, the management consists when the brain injury is mild to moderate, there is no need for treatment. Management can be observing the person at home after ruling out any compromise of the brain or tissue by subarachnoid hemorrhage or any hematoma. But when the brain injury is intense, is severe, serious, the admission is warranted in a trauma center where the CT can be done and the adequate intervention can be done, which entails to drainage the hematoma surgically and the support for the viral respiration and the circulatory status of the person. So this concludes our presentation. Thank you so much.